Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. Good evening, dear colleagues and friends. Welcome again to MEOM activities. And we hope that you have a good time and you are all safe. Today, we will have a very interesting topic also that we are all the time facing in our clinic. And with me today also a very pioneer speakers, well-known figures that you can learn from their expertise, Dr. Ayman Mdanat and Dr. Patricio Lorenzo. So without any further delay, I think we can start with our speaker, Dr. Patricio, for this meeting. Dr. Patricio.
Yes, thank you, Dr. Amri, for your kind invitation. And for the company of Dr. Ayman. Sorry, I have the HDMI connected, so we'll go back.
Yes.
So thank you for the invitation. As I told you during the debate before the talk, I think that there are some things that we should be looking after when we face patients with retinal vein occlusion. It is a very common question when I face my residents or my fellow colleagues. So you can diagnose our retinal vein occlusion, but after that you don't know if you have to look for something else, if you have to investigate the patient, if the patient has to be referred. So I'm going to just go through a quick overview of the main systemic associations that we face when we see a patient with CRVO or BRVO. I'm not going to talk about local, so eye complications, like, for example, increased intraocular pressure, so only systemic associations. So talking about the demography of RVO, roughly it depends, but mostly the numbers for men and women are about the same. The Beaver Dam for them is about the same. For the Germans, there are more men with RVO. For the Koreans, there are more women for the RVO, but the differences are not really big. The age also is important, as these vein occlusions occur in patients that are usually more frequently over the age of 60. Also, there is a difference for patients, young patients below 40 years of age. They have a higher incidence of CRVO, while then as the patients get older and older, then BRVO takes the lead and the numbers overrun the numbers of CRVO. These are the associations we will be talking about. You can see that we have hypertension, diabetes, ischemic heart disease or cardiovascular disease, dyslipidemia, chronic kidney disease, thrombophilia, and then two, let's say, funny associations like gastroduodenal ulcer of inflammation and benign prostatic hyperplasia. That we will not be talking about them during the talk, but we can talk about them after the talk during the discussion. So hypertension is the more frequent association. And don't forget that putting the patients in a normal blood pressure doesn't actually prevent the risk of having a vein occlusion. Why? Because the changes in the vessels, the AV nippings and the like are already made. And yes, you can normalize the pressure, but you cannot reduce the risk. Definitely, these patients now, as we all are in JCI, or we have to pass JCI, at least in Dubai, blood pressure is checked in every visit at the vitals. But definitely checking blood pressure in a patient presenting with vein occlusion is a must. If you have any doubt, if you have any problem, if the blood pressure is not controlled, then you have to refer to a specialist. I prefer to refer them to nephrology, but you can refer to anyone dealing with hypertension. Diabetes mellitus. Of course, diabetes mellitus type 2 is a debatable isolated risk. When we talk about patients with just diabetes type 2 with no other risk factors, it seems that the risk of developing RVO is not bigger than the normal population. While the risk increases if this is associated to hypertension and dyslipidemia, and the risk is higher with diabetes and the other two than the number of for every single complication alone. Also, you have to know that in patients presenting with RVO, diabetes mellitus type 2 is more frequently seen than in the normal population presenting with RVO. If you don't know if the patient has diabetes, then again, it's a must to investigate these patients for diabetes. Cardiovascular disease, both myocardial infarction is increased in patients with RVO, and stroke is also increased in patients with RVO. So if you have a patient presenting with vein occlusion, with no previous stroke or no previous MI, I think you should also send this patient to cardiology for further investigation, to neurology or to internal medicine. Just a bigger risk of having any of these two dreadful complications. For dyslipidemia and others, it's clearly that LDL levels, elevated LDL levels, increase the risk of having vein occlusion. Also, carotid plaques that we think of them when we have a CRVO, central retinal artery or central retinal artery branch obstruction, there is an increased risk for RVO in patients with these plaques. Smoking also is carrying an increased risk for these patients. So these things are easily investigated. You pulse your carotid, you check the pulse of the carotid, you can use your stethoscope and look for bruits, or otherwise send these patients for investigation. Chronic kidney disease. There is an increased prevalence of RVO in patients with this problem, especially for those with end-stage renal disease. Who are they? Well, the ones who have, they're in a dialysis program, or the ones that are just waiting for a kidney transplant. Also, there is increased prevalence of renal disease in patients with RVO. So it's also worth it to send them for investigation. And then the thrombophilic factors, the hematological disorders. Some of them are debatable, but hyperhomocystinemia conveys an increased risk for RVO. Anticardiolipin antibodies, which is part of the antiphospholipid antibody, they also have an increased risk. Lupus anticoagulant and antiphospholipid antibody, there are papers saying that they're actually also they have an increased risk. Some papers they say that the risk is the same as in the normal population, and factor 5 Leiden is not related. And I think that we need to talk about this at the discussion, and know that Dr. Ayman has interesting cases to present. And thank you for your attention.
Thank you very much, Patricio, for this excellent and comprehensive presentation. I think if you go one by one, you go very fast on the presentation, but I think every single risk factor, it's need per se a discussion and talk about that. I will leave to Dr. Ayman if you have any question. There is some question in my mind. Also, I remember all my dear friends, they are here with me, participants. They can raise the hand if there is someone want to participate live, or they can send their questions in question or in chat, and we will have our expert to answer this. Before we go, Dr. Ayman, to your presentation, if you have any comment or question to Dr. Patricio.
No, at all. Dr. Patricio have listed the causes very nicely. I can add also some of the rare cases, inflammatory problems, macroglobulinemia, multiple myelomas. These are blood dyscrasias. These are rare causes that you have to look at, especially in young patients, not as Dr. Patricio. In older ages, I think hypertension, diabetes are the most common.
Before we move to you, Dr. Ayman, also, Dr. Patricio, you are mentioning most of the time there is, for example, a high risk. If the patient is diabetic, there is a risk to have an RVO, whatever, central or branch, for example. This is an example. At the same time, you are saying in other like hypertension, or in cardiac, especially in cardiac, you mentioned, there is a risk of having a cardiac problem. Do you mean RVO can cause? the cardiac problem,
all
or you
these,
mean, okay.
All these things are, let's say, coming together under atherosclerotic changes. So when you have a patient with RVO, maybe it's the first manifestation of something that it is going on, and one of them could be a myocardial infarction or a stroke. So in the end, RVO is a stroke, because the retina is a central nervous system. And especially, as Dr. Ayman said, and I know that he has a nice case of a young patient, the younger the patient, the more you should be aggressive with investigations. You don't want to see your patient coming with a stroke after an RVO if the patient is 45 years of age, or coming or dying after a myocardial infarction because you said, well, you're hypertensive, you're already well kept, and everybody's looking after you. No, you should actually be a little bit more proactive, especially the younger the patient is.
Absolutely.
Okay, what I mean, Dr. Patricio, if the patient is having a myocardial infarction or any other cardiac problem, it may lead, you mean, to RVO, and it could be a manifestation, an early manifestation that seen. So you have to go for that to check. That's what you mean by, especially like also hyperlipidemia and the others, is the way, but not the opposite. I mean, RVO, it cannot cause a myocardial infarctions.
No, but it could be the presenting sign of this atherosclerotic disease, that it is somehow subliminal. Maybe the patient is very relaxed, has an easy life, and is not exercising, but tomorrow he goes for a run and he dies out of a myocardial infarction. So it's a warning sign. It's a warning sign that deserves to be investigated.
Okay, Patricio, also there is smoking. How the smoking it can increase, I don't know if you have an idea, I mean, or anticipated, I mean,
again, smoking is reducing blood flow because it produces vasoconstriction, and in the end, this is something like a rheological problem. All the obstructions, all the occlusions of the arterioles and the veins. So it seems that it doesn't actually benefit you from smoking to have a, let's say, healthy vascular status. And if you link this with any other risk factors, then you have a dreadful combination.
Thank you very much, Patricio. We can now move to Dr. Ayman and the case's presentation, and we will have a discussion. Dr. Ayman, which one you prefer to stop in the middle, discuss, or we can go until the end, then we can discuss which one?
I think while I'm discussing the cases, I will stop and discuss few points that I think it's important.
Okay.
Thank you, Dr. Mohammed. Good evening, everybody. Thank you for the nice invitation. And it's always good to see you, and it is a nice opportunity to see Dr. Patricio too. Long time no see. So thank you very much. Let me present my first case. Is a 65-year-old male patient. He's hypertensive. He presented with sudden blurring of vision in his right eye. His vision was 0.7. He's phakic, clear lens. Pressure was 14 millimeter mercury, and there was no rhabiosis. CBC, blood chemistry were normal. The patient was on Crestor for hyperlipidemia and Atacand 8 milligram for his hypertension. This was his fundus picture when he presented. You can see typical features of CRVO, dilated tortuous vessels, deep hemorrhages, retinal edema. You can see even some collaterals on the disc, maybe because of his a previous attack. Who knows? But he never complained before. But this is a typical case of CRVO. Now, this is the OCT angio. You can see that he has relatively good perfusion, very minimal areas of non-perfusion over here. But above all, the perfusion, this is the superficial, and this is the deep. Now, if you look at the deep capillaries, there is some ischemia in the central part of the fovea, which probably explain the presence of edema. This is the choroid, nothing significant. Now, As a plan, we decided to send him for his doctor to recheck his blood pressure and revise him, and we started giving him Eylea injection monthly. So this was in July 2019. He was given in July one injection. He was given in August, and in September this photograph was taken in August, the 17th of August. You look that the patient was back to 6/6 vision, and his edema has disappeared completely. Now, this was in October, like 3 months, 4 months after the initial insult. Still, his vision was 6/6. Now, he came back in November. You notice that he started to have some edema. Although his vision was 6/6, we gave him an injection of Eylea.
Dr. Ayman, if you allow.
Look, I want just to stress one point. If you go to the HD photograph, it gives you more information about the edema rather than the colored one. So whenever you have this, make sure to have the HD photograph in order to assess the edema. Let me just say a few things. Now, when we treat the fresh or naive central retinal vein occlusion, we start by Anti VEGF injection until we dry the macula and until we achieve the best vision. Then we have two ways, either to treat and extend. This is the way that I love. This is the way that I like in dealing with retinal vein occlusions. Or you can go to the pro-Renata PRN regime. This patient did not want to continue taking the injections. He told me, I will come back whenever I feel that my vision is blurry. And I said, you have to come back every month to check if we are going to go through the PRN regime. He said, okay, but this will tell you that the real life cases are really different from the textbook or from the studies that we know about, because patients sometimes they don't let me say comply with your orders. So this was in November 2019. He was given Eylea injection. He came back in December. The edema was worse. So look, this was in November. He was given Eylea. He came 1 month later. He was worse. What to do? I can ask my colleagues if they want to comment. What to do at this stage?
Okay,
Shall
Patricio?
we continue? Shall we continue? Shall we shift? Shall we?
What do you think, Patricio? What is your opinion?
This same as in diabetic macular edema. This is a patient who has had a very good response to one specific anti VEGF, and now is getting a relapsing edema. We all know after the retain study 4 years result that these patients after 4 years, 50% of them still will need some injections. I will definitely give another PRN, probably same anti VEGF injection.
Yeah, in fact,
even Dr. Patricio, Dr. Ayman, I think he mentioned here, he took 1 injection of Eylea, but he didn't improve. That's maybe the question I think, Dr. Ayman, you are highlighting, right?
Yeah,
so do we shift? Do we need to shift to another or to continue on the same anti-VEGF? Patricio, what is your opinion?
I would continue for up to 6 injections with the same. He's responding.
I totally agree with. I totally agree with Patricio. We go ahead. We continue on Eylea.
Okay.
But what happened? In fact, the doctor who saw this patient in the center, she listed him for Lucentis. I don't know why, but she put Lucentis, and he was given Lucentis. It was not intended to shift, and I never shift because of this. I totally agree with Patricio. I would continue up to 6 injections, and then I'll show you an example later.
Dr. Ayman, before you move, I want to ask you and Dr. Patricio, whenever the patient is coming as a naive patient and he have a central retinal vein occlusion or branch retinal vein occlusion, there is, I mean, you will give a 3, for example, loading dose, or you are going to start until you dry, even it will dry within 2. For example, your patient dry after the second injection, right?
Yes, I continued. I usually give 3 injections, especially in retinal vein occlusions. Retinal vein occlusions, they need repeated injections, believe me. And I will show you later on, you will see among this case that those patients, they need follow-up, prolonged follow-up, and they need more injections. So I start with 3 injections. If they need more, I will go for 4, 5, or 6 injections until the macula is dry or until they have a stabilized visual acuity. This is what I do.
Dr. Patricio, you have something same or different?
No, I agree, especially in these cases that if you remember the color picture, there was no cotton wool spots. We don't have a fluorescent, white field fluorescent angiography that I usually routinely do for patients with CRVO. But let's think that as there were no cotton wool spots, this is a
ischemic changes.
A well-perfused CRVO, and these people are going to have edema much more than the ischemic ones. So yes, I would go on for at least 3 injections, yes.
How about Dr. Ayman, before we move, sorry to interrupt you again. There is a difference if you are dealing with central or branch vein occlusion?
Let me just say one thing that Dr. Patricio mentioned, which is very important. Those patients, you need to do a fluorescein angiography in every naive patients. We've done fluorescein angiography. I'm sorry that we don't have the fluorescein of this patient, but did not show significant, very little ischemia, very small patches of ischemia. So the fluorescein angiography is very important. Now, when it comes to RVO, retinal vein occlusion, or CRVO, yes, when I'm starting, I give the same. I give 3 loading injections, and then I assess if the patient is responding or not. The only difference, which is significant difference between central retinal vein occlusion and branch retinal vein occlusion, is that the macular edema and branch retinal vein occlusion that responds to laser treatment. And contrary, the central retinal vein occlusion, the response is not that good. But otherwise, regarding the anti VEGF is the same.
I think we will also pass on this one, Dr. Ayman, maybe after you finish, because I think at the end we need to give also in branch retinal vein occlusion, a laser. Not only even if the patient is respond, we have to give, otherwise there will be an ischemic changes and it will affect, and there will be again of
this is what I'm saying.
A recurrence more.
Laser treatment is indicated in branch retinal vein occlusion.
When are you doing, Dr. Brown? When?
The patient visually respond in contrary the central retinal vein occlusion. We don't do except if the patient develop robiosis iridis, then you have to go ahead and do a PRP for the central retinal vein occlusion.
For branch vein occlusion, when are you going to do the laser usually?
I do a very sectorial ischemia. In fact, after the improvement of macular edema, I used to do a focal laser treatment for that.
After how long, you are keeping, for example,
if the patient dries, let's say after 3 months, I'll do it after 3 months. If dries, because as you know, if you are going to do laser treatment, this might aggravate the macular edema.
Yes, that's why I'm asking.
It's more important. So you dry the macular edema first, then you do the.
No, I mean, Dr. Ayman, after the drying of the macula, do you give a space, for example, to 1 month, then you start giving the laser, or immediately after drying?
No. When the patient comes to you, you do an OCT, you find that the macula is dry, you go ahead and do laser.
Okay. Please, can you just keep the backup, excuse me, management, can you please keep the other person mute the others, please?
Yes.
Yeah, can you mute? Okay, yes, thank you.
Okay.
Okay, sorry, Dr. Ayman, please. Okay.
So this patient was given, this was, let me just remind you, this was in November and this was in December. He was given Lucentis. and the patient came back in February, and the macula was dry. And on the 23rd of March, he was given another Lucentis injection, and the patient came back in June. His vision was 6.6, and the macula was dry. Now, in October, he came back with macular edema, and he was also given another injection of Lucentis. Now, he came back in December, decreased vision, 0.9, and he was given another Lucentis injection. I want you to just bear with me. This was December 2020. He was given Lucentis injection. Now we are in January, and after the Lucentis injection, the patient worsened. He came back with 0.6 vision. So
this is 2021.
This is 2021. This was December 2020.
Yes.
And this was 1 month after the Lucentis injection, the patient worsened. What would you do? So at this stage, what I did is I gave the patient another Lucentis. This was January 2021. And then on the 25th of March, I gave him another Lucentis. His vision was the same. His edema was the same. He was not worse. And in May, I gave him another injection. This is the answer of your question. Would you shift? No, I would not shift. I would, as Dr. Patricio said, I will continue on the same anti VEGF or at least 6 injections before shifting. So I gave him December, January, March, and I gave him another one, the 4th injection in May 2021, and the patient improved after 1 month. This was June to 6.6, and this was in July 2021. He came back with decreased vision. I gave him another Lucentis injection, and he came back at the 29th of July with 6.6 vision and dry macula. So we don't shift at the first, let's say, sign of worsening of the edema. We continue at the same anti-VEGF. Patients usually they will respond. We don't say that they are non-responders except after 6 injections. So this was in July. This was in July 2021. The vision came back to 6.6.
Dr. Ayman, you are managing here in BRN. I can see that.
This is PRN. This is what I'm telling you. The patient refused to do treat and extend, although I prefer to treat and extend in CRVO. But
I mean, there is a difference between when we are dealing with macular edema due to diabetes and due to branch vein occlusion. I mean, because BRN we are not usually so most of the of the retina they are not anymore doing this one. I don't know if that's for macular edema.
Let me tell you this: the macular edema in diabetic patients is more forgiving than the edema in retinal vein occlusion. If you delay or if you don't treat properly and early in vein occlusion,
yes.
the patient the edema usually becomes more resistant to treatment in our retinal vein occlusion rather than diabetic patients. And diabetic patients, as I said, the edema is more forgiving. Now, if you don't treat early and aggressively and properly in patients with RVO, the edema will become persistent and become resistant to treatment. And I've seen many cases of retinal vein occlusion who lost vision even after dying of their edema because of the chronicity of
ischemic changes,
and ischemic changes in the macular area. So in RVO, you have to treat aggressively and to treat as early as possible. This was in September. He was given another injection, and he came back in November last month. He was given another injection, and he came back to me a few days ago. His vision was 6.6, and I think he's listed for another injection in next week. What I want to tell you, just going through this case, that those patients need follow-up. Some say you need to follow up them for 2 years. No, sometimes you may need to follow them more than 2 years, especially even if the patient has no significant ischemia, but you need to follow them up properly. You have to treat the risk factors. If there's any uncontrolled blood pressure or diabetes or hyperlipidemia, has to be treated, and those patients has to be followed up for prolonged period of time, and they have to be managed properly.
Before we move to next, you are moving to the next presenter.
Any question from that?
Yes, Dr. Ayman, there is some question here, I think, came from our colleagues, Dr. Mohammed Al-Musa. He was asking about before, when did you start injection after diagnosis of RVO? Early as you can, or you delay it? I think you answered this one, because I think as early as possible. The other question, when did you do OCT after the injection to see the effect of injection?
I usually do it after I finish my third injection. But in this case, because the patient was, said, I improved, I want to see, I did it in August, after 2 months, by the end of August. But usually I wait until I finish my third injection.
Okay. Dr. Ayman, what is, if there is any role of steroid in treating?
I'll come to that by my third case. Can we
okay. Okay. So Patricio, if you have any questions, Dr. Ayman, about this case?
No. The only thing that you would like to just remind is when you see a patient with CRVO especially, and especially if it is ischemic, I check always for especially during the first 3 months, for iris rubeosis, because they can develop neovascular glaucoma. So that's something we have to check always in patients with CRVO.
Absolutely. And to add to that, also you have to do a gonioscopy.
Yes.
Not just to look for the fundus, you have to do a gonioscopy just to rule out rubeosis in all of these cases. Absolutely.
I think I have one
This is the fundus of the patient. This is the fundus of the patient recently. It came back to normal, although it has some AV crossing changes still. And this is his OCT angio. It's quite normal and very good perfusion. Now,
okay, Dr. Ayman, I have only one comment before you move to the next one. Also, there is things that I want to mix between your presentation or your case you present and what Patricio said. I have a case with branch retinal vein occlusion. She was young, almost in the end of the 40s, and she is hypertensive. When I saw the patient, she was having a branch retinal vein occlusion. I started her on Lucentis, Anti VEGF, and after the third injection, she was coming only to check. She was having a good visual acuity. Even she is having a branch retinal vein occlusion. There is even a hemorrhage. There is macular edema, but it's affect little bit blurring, but it's usually can say 6/6 partially. And I give her 3 injections. The follow-up after the third injection, she came with hand movement. She is having again of repeated same area of branch vein occlusion, severe macular edema. It's more than previous one, with hemorrhage also. And when we check also the pressure, because we are routinely check in our clinic the pressure, then we find it very high blood pressures. I think we need also to check, and I send her, even before I send her to the patient to the medical, and she is on antihypertensive, but I think she didn't go. This time, immediately I shift her to the emergency and guide her to go directly to medical for checkup and to control the blood pressure, because otherwise what we are doing to manage, it will not change if she is going to have a very high blood pressures. This is the comment. Just I want, if there is any comment about this one or
let me. You asked me about steroid. Let me just say a few words about steroid. The Geneva study have shown clearly that patients have benefit from Ozurdex 0.7 milligram injection regarding the edema and regarding the features of retinal vein occlusion. Myself, I don't use Ozurdex or steroid as a first-line treatment except in 2 cases. If the patient has a recent cardiovascular event and he has a CRVO, yes, I don't use the Anti VEGF. I will start with the steroid directly, bearing in mind that he's not a steroid responder. And in some cases, if the patient is away and he cannot come back every 1 month or 2 months for revision, if you want to go for a few months, I might consider steroid, bearing in mind that, as I said, he's not a steroid responder, and to make sure that he's able to check his intraocular pressure 1 month after the injection. This is regarding steroid, and we're going to talk a bit more in the 3rd case. Now, how to manage young patients with RVO? I think this is an important question. This is a 46-year-old male patient. He presented with sudden blurring of vision in his right eye. He has no history of hypertension or diabetes. He's not taking any medication. He was completely healthy. His vision was 0.6. He did not improve. He was phakic with a clear lens. Intraocular pressure was 16, and he has no rabiosis. This was, if you look at the fundus picture, you see that there is a significant ischemia. You see this cotton wool spots. You can see the hemorrhages, deep and superficial hemorrhages, dilated tortuous vessels. Look at the narrowing here of this venule, and over here and over here and over here. You see, it's a puzzling picture in a 46-year-old patient. This is the macular area with edema. Now, what we did, in fact, we did a medical consultation to rule out hypertension, diabetes, or other systemic disease. I sent this patient to my colleague for consultation. We did blood chemistry, including fasting blood sugar, lipid profile, CBC, ESR, and coagulation profile. In fact, his coagulation profile was not bad, but his ESR was very high. This was his OCT. He has a significant edema in this OCT angio, as you see. So, how to manage this case? What would you do? After the consultation, would you start the same with Anti VEGF? Do we start with steroid? This was a question. Can I stop here to discuss, or do you want me to? Yes,
go on. Yes, it's very nice.
What did I do?
Okay, let me ask Patricio. What do you think, Patricio? If this is your patient, what are you going to do after you send for consultation, after you do all the investigation? Yeah. So are you going to start immediately treatment of the patients?
Yes,
this was his OCT angio. You can see that there is a significant
ischemic changes. Yeah.
In these cases of young people, I would like to rule out lupus antiphospholipid syndrome. That I don't know if it was investigated or not. I remember a very young fireman that I saw myself presenting with something like this 20-something years or many years ago, and he ended up having a lupus antiphospholipid syndrome. So the important point is we are not dealing with only the problems in the eye. As I said before, we have to think, especially the younger the patient is, in systemic problems that we have to thoroughly investigate. in this case, if there is no other risk factors, I would start with anti VEGF as well. Even with the ischemia, I will give my patient some sort of opportunity to improve with anti VEGF. It's a phakic patient. First presentation, I'd rather personally go with anti VEGF. I don't know if Dr. Ayman was of the
Yes, I totally agree with Patricio. Definitely, what you said is absolutely right. But what puzzled me, in fact, in this case, is the fundus picture itself, the ischemia that is present. Usually, those patients, the young patients that present with mostly with CRVO rather than branch vein occlusion, they usually present with central retinal vein occlusion. They don't have that ischemia usually. That it's mostly non-ischemic. This is one, and the fundus picture does not look that aggressive. Although some patients they come with scattered hemorrhages, retinal edema, etc., and macular edema sometimes. So I thought of systemic problem. In most of the cases, we think of coagulation profile problems as you said, antiphospholipid or protein S problem or whatever. In fact, this patient was diagnosed with multiple myeloma. Unfortunately, he had multiple myeloma and he was referred. This patient, I totally agree. I would start with anti-VEGF, 3 injections, 4 or 5 injections, until I dry the macula completely. Now, coming to ischemia, according to the guidelines of the Royal College of Ophthalmologists, any patients with less than 10 disc diameters of ischemia, you would treat, or with vision better than 696 or 20/30/20, you can treat with anti-VEGF. Now, patients with extensive ischemia, more than 10 disc diameters, with very poor vision, they found that the anti-VEGF is not giving any benefit, so you can observe, if you want, until the development of rabiosis, where you can treat with anti-VEGF and laser treatment. Unfortunately, this patient was lost after he was diagnosed with multiple myeloma. He was lost for follow-up.
Dr. Ayman, I think if you want to highlight some points here, just to learn from this case. This is a central retinal vein occlusion whatsoever. I mean, whatsoever the cause, I think we need to treat. Unless, yes, as you mentioned, there is a very large ischemic changes, and that there will be no benefit. But even, yes, though you can give at least one even injection, sometimes, I mean, we cannot estimate exactly this patient is having that much of ischemic changes. So we can give, but even at least one injection. Do you agree on that? So you can.
I agree. I usually treat even patients with severe ischemia, and
sometimes some of them they get.
I give anti-VEGF because I see this, although they were not benefit vision-wise or ischemia-wise, but I think it might decrease the development of rabiosis in these cases. Might. This is.
And sometimes, Dr. Ayman, even they are getting.
This is not scientifically 100% what I'm saying, but you have to give your patient something. But in fact, those patients with very poor vision, when you say less than 696 or less than 320, you're talking about counting finger vision. Patients counting finger vision with severe ischemia, usually they don't. And you know, the anti-VEGF, especially if they are paying, their private patients they are paying, you have to bear this in mind.
Okay, there is one question, Dr. Ayman, from Dr. Qasim Al-Hamouri. I think he is sending a regards to you.
Dr. Qasim is one of my colleagues. Misal khair, Dr. Qasim. Good to hear from you.
Do you think anti-VEGF can help in washing out the thrombosis inside the vein if given early after the occlusion?
I don't think it's related to the washing out of the thrombus from the vein itself. No, it will decrease definitely the vascular endothelial growth factor concentration in the vitreous body. So it will decrease the edema, and it will decrease the chance of development of rhabiosis later.
The second one is from Dr. Walid Al-Rt.eye. Would you use Ozurdex as the first-line treatment in phakic patient with clear lens?
Yes, as I said, if the patient came to me with the CRVO, primary retinal occlusion, and the recent cardiovascular event, I think it's risky to give them those patients anti VEGF. Yes, I will start with Ozurdex injection, keeping in mind, as I said, that the patient is not a steroid responder, and definitely you have to keep an eye on the intraocular pressure afterwards. The other situation, if the patient is living very far away and he cannot come for like 3 or 4 months, yes, I would consider treating them with Ozurdex. Although, if the patient, especially if he's pseudo-phakic, this will encourage me to use Ozurdex.
Dr. Ayman, let's suppose that we give the patient an anti-VEGF and he improves. Then you find again what you have in the same case that you presented firstly. What is the problem to give, for example, Ozurdex instead of, if he is central retinal vein occlusion and you give him for a while, then you are watching him, especially if he is not a steroid responder and he don't have and if it will be, as you mentioned, if he's a pseudo-phakic.
This is what to do for non or partial responders. Is this your question?
Yeah, I mean, why not to instead of continuing giving BRN, for example, anti VEGF, and you know.
Well, if the patient is phakic, no, I will not.
No, we are talking pseudo-phakic.
If the patient is pseudo-phakic,
or if Dr. Ayman is a phakic and he is an old age, you know, sometimes some of them have an early cataract, and sooner or later he will have a cataract.
Let me answer you. If my patient is responding to my anti-VEGF, I don't think of shifting to Ozurdex, in fact, except if the patient is having a burden of this 2-monthly injection. He wants something that that might delay the injection more. I might think, especially if the patient is a non-responder or if he is pseudo-phakic. Yes, you might think of Ozurdex as an option. Otherwise, no. Why not? If the patient is compliant and he's coming every 2 months for his anti-VEGF and is not complaining, no, I would not think of shifting to Ozurdex.
Okay, the last question before we move to Dr. Ayman, from Dr. Nuha Al-Fayoumi, is there any risk from applying the laser immediately after the injection? I mean, on the next day of taking the injection in case of macular edema with area of ischemic in case of CRVO?
Now in CRVO, no, I don't give macular laser treatment because definitely the papers and the studies have shown that there is no benefit of doing macular laser treatment for patients with CRVO. In the contrary, patient with branch retinal vein occlusion, yes, you might go ahead and do this. But nowadays, in the event of anti-VEGF, I don't use. And if I'm going to use any macular laser, I do a micropulse laser rather than an argon laser.
I think there is one question, Dr. Ayman, Dr. Patricio here answered in a chat from our doctor, I think Dr. Iyad. Why don't you start injection with Avastin? I mean,
yeah,
I know here in UAE is not allowed. It's not licensed. Not licensed, but I don't know. I think there is another country they are using. Do you have any experience to use also Avastin instead of Lucentis or Eylea?
Yeah.
I'm asking Dr. Ayman because for us, no.
Yes, for us, in fact, most of my patients, say more than 60 patients with retinal vein occlusion, I start them on Avastin.
Okay.
Definitely, and they respond. They respond.
Yeah, I agree. I've been using Avastin in Spain and also when I was in Riyadh, and they respond.
Okay, I think we can continue, Dr. Ayman, please.
My question now, what to do for non or partially responders? By saying this is if you have central retinal vein occlusion or partial retinal branch vein occlusion patient and you start him on anti VEGF and you give him 5-6 injections, the response was not good or he did not respond at all. What to do? This is a 71-year-old male patient, hypertensive, with history of branch vein occlusion, treated with multiple anti-VEGF injection with no significant visual improvement. In fact, this patient came to me, he had 10 injections of Avastin, 10 Avastin injection, but he did not improve at all. His vision was 0.05, no improvement. He had lens opacity and his pressure was normal and there was no rabiosis. Just to mention this was the periphery of the retina, and this was his OCT angio. You can see that the patient has subretinal fluid and he has subretinal pigment epithelium, subretinal and intraretinal fluid. This is the OCT angio. We can see that the patient has some sort of ischemia here, and this is the deep capillary. He has more ischemia. We can see he has ischemia here, he has ischemia here, he has foveal ischemia. You can see it here. So he has significant ischemia in his macular area. So what to do? Let me answer you. In these cases, after 10 cases or 10 injections of Avastin, I gave him Ozurdex injection. In this case, I think steroid is highly indicated. I don't shift to Lucentis, I shift to another anti-VEGF. After 10 injection of anti-VEGF of any type, I resort to Ozurdex injection. So definitely I gave this patient Ozurdex injection. This was the 28th of October 2020. And then this picture was on the 21st of December, 2 months later. You can see that the edema here is much better, although this is the vertical, the upper part of the retina still they had some edema, but definitely he improved. And his vision improved to 0.2 after 2 months. But the problem is that his intraocular pressure was 30 millimeter mercury in the right eye and 20 in his left eye. So I gave him a Zarga treatment twice a day, which controlled his pressure. Now, the question is, what would you do? Would you repeat the Ozurdex after 1 month, after 3 months of the start of the injection? Or would you do micropulse laser? Or would you do? Let me open this.
That patient was a branch retinal vein occlusion, right?
This was a branch retinal vein occlusion, yes.
Okay. Doctor, let me ask Dr. Patricio before I give my opinion. Okay.
Yeah, I'm not proficient with micropulse laser, but I mean, you can try. I probably would go for a repeated Ozurdex injection. If needed, increase the anti-glaucoma medication. Even further, I remember one case that we had to remove the Ozurdex rod from the vitreous with pressures over 45 to 50, and the patient ended up with a trabeculectomy or a valve. I don't remember now. So yeah, Ozurdex can produce these things, but the benefits are really, really good when it works. So I wouldn't hesitate to go ahead with a second Ozurdex, to be honest. If I had micropulse laser, it's practically straightforward, little risk. It's an option. I consider it is an option, yes.
Dr. Patricio, why not normal laser? Is a branch retinal?
No, I don't use thermal laser for grid any longer for years now. If I see something like a leaking, few leaking microaneurysms, yes, I can laser them, but I don't use grid laser for many years. I was never really a believer of the grid laser treatment, to be honest.
I mean, this one, we are usually treating the patient with branch retinal vein occlusion, and we are treating the ischemic changes with the laser, grid laser.
Maybe you, I don't. No,
Dr.
no.
Ayman?
No, I totally agree. It's been ages since I used the argon laser.
But if you don't have micropulse laser, what are you going to do?
I tell you, I used to do focal laser treatment, and I used to have good results, but not anymore. I have the micropulse laser in my center.
No, suppose, I mean, not everyone scientifically we are talking, not according to, I know micropulse is better, but 99% of the, I mean, the retina, they don't have micropulse.
I'll tell you, if I don't have micropulse, I only use the Ozurdex, except if there is only, as Patricio said, some leaking microaneurysms that they are significantly leaking. You can target them with laser. Otherwise, I don't use the grid laser anymore.
No.
But I mean, Dr. Ayman, I want to highlight this point, not for me, for everyone. We know that in case of branch retinal vein occlusion, one time you need to give a laser to treat the ischemic changes. Otherwise, it will be a problem there. So even if you give, it will be repeating. What do you think?
Let me tell you, scientifically, if you go to the studies, you still can use the grid laser treatment.
Okay.
It's not contraindicated. Just to highlight this point. It's not contraindicated in branch retinal vein occlusion to use the grid laser treatment. But personally, I don't use it anymore, but because I think it is destructive, because I've seen some cases of expansion of the laser scars underneath the fovea, which led to loss of vision years after the focal laser treatment. So I don't use it anymore. Although scientifically you can use it, but with the presence of Ozurdex injection, with the presence of steroid injection, I don't think you are in need to do the grid laser anymore. And if you have the micropulse laser, this would be a very good addition to your treatment, which has no harmful effect on the macular area.
Okay, the question now, how many times you will repeat the Ozurdex? I mean, you know, there will be sometimes, you know, it can continue more than years.
In my practice, 2, maximum 3 injections. Usually you can control your edema. I never used the Ozurdex more than 3 times.
Okay, that's mean within every 6 months or every 3 months? 4 months?
Every 3 to 4 months.
Every 3 to 4 months.
Yes.
You have any other different opinion, Dr. Patricio?
No, I completely agree with Dr. Ayman, especially for the laser. I don't do grid laser. It's been ages since I have done my last grid laser for any pathology in the retina. Really ages. And if you have to do for macular ischemia, it's not going to give you rubeosis or new vessels or anything like that, because the surface, the area of the macular ischemia is very small. You can only think of rubeosis, or you can think of MVE, MVD, if you have a huge extension of ischemia. And then you can perform the PRP, which is not going to change too much the status of the macular edema, that you should treat as a, let's say, within the context of CRVO, as a different disease from the peripheral ischemia.
How about in central retinal vein occlusion, CRVO? I mean, if there is like what we have seen with Dr. Ayman, a lot of ischemic, I mean, not the same case, ischemic changes, and it may lead now to rubeosis iridis, you will go and do PRP, right?
Let me answer this. If the patient has a significant ischemia, more than 10 disc diameter, I think there is a good reason, even if there is no rubeosis at this stage, and if you are afraid that the patient will not come back, to do a prophylactic PRP in these cases. If you have a significant ischemia, yes, I sometimes do a PRP even before the appearance of rubeosis iridis in these cases. I don't know if Patricio agree with me in cases of severe ischemia.
Yeah, I agree. I also treat severe non-proliferative diabetic retinopathy sometimes with PRP if I cannot trust the patient. So a patient that is going to disappear and you don't never know when it's going to come back. What are you waiting for? Just do the PRP now that the patient is there, or at least start your PRP because you're actually preventing further damage to this patient. Not because it is a real indication in an ideal world where all these patients for the randomized trials, they go and they attend every single visit. That's not the real world. So yes, I mean, it's not coming in the books, but definitely I think that most of us are doing some sort of prophylactic PRP for this subset of patients. Yes, I agree.
Yeah.
I think we came to the end. I think it's very nice and excellent discussions we have from our dear Professor Ayman and my dear friend Patricio. Is there any question or any comment from any one of our colleagues? They are following us or they want to raise hand and to participate, to have another opinion or any questions. I have here, why do you, I think we have done this one, these questions. Let me see, there is one question. When did you start? Okay, I think most of the question has been answered. So anything before we come to conclude this from Dr. Ayman, or I mean, if you can give us, I mean, the conclusions in your mind from our session today, and then Dr. Patricio.
Yeah, thank you so much. There is one question that it seems that Dr. Hashim Altaba is asking how to get the certificate of attendance.
This one, okay, I will answer that. I'm thinking of medical question. That one I will answer before.
No, medical questions. I'm very happy of being attending the webinar because you always learn a lot, especially with Professor Ayman. That is very knowledgeable and presenting very nice cases. Thank you.
Thank you, Patricio. The same to me. It's always nice to hear you presenting. We always learn. The problem is when you stop learning. This is the problem.
True.
Every time we learn a bit.
No, I just want to wish a happy season for New Year's Eve, Christmas for the Christians, and for the rest, Happy New Year's and season, because I will be going home for holidays. So hope you have a great time, all of you, over this end of the year, and you have a healthy 2022.
Thank you very much, Dr. Patricio. Thank you, Dr. Ayman, for this and excellent presentation and discussion. I want to highlight only one thing before we end this. We need to treat a CRVO or branch as soon as possible. This is the most important. I think the others, we are having no difference in the way we are dealing with these cases. And the most important to start immediately. And you have also to to send or to refer the patient to see if there is any systemic diseases related to that. And that's what I want to say. At the end, also, I would like to thank all participants. They are with us, and they will receive all their certificate by sending to their email. And also, I want to announce now for today, we are going to have our quick, the 7th quick, next year in 2022 in February from 10 to 12. Query, I don't know if we are going to change because we are in UAE, we change our weekend. It will start, it will be Saturday, Sunday, and we will have working on Friday half day. So maybe we'll start, if we now the time of the quick on Thursday, Friday, Saturday. Query, we will see how is the things is going on. Maybe it will be shifted from Friday to Sunday. We will update you soon, and you will get the announcement and the save date soon to all our colleagues. Thank you very much, Dr. Ayman. Thank you, Patricio. Thank you for the management event. And thanks a lot for the Alimera and for Balqis from Alimera for sponsoring this meeting. And we hope that Happy New Year for everyone. And we hope to see you, inshallah, next week. We'll have one session before the end of this year. It will be on Friday.
Thank you, Dr. Mohammed. Thank you. Thank you, Dr.
Thank you,
Mohammed.
and thanks a lot, and good night. Thank you very much.
Thank you for the MEOM.
Bye-bye. Bye-bye. Thank you, Michael. Thank you for other colleagues at all, and we will communicate with you soon, inshallah. Thank you very much, and good night.
Thank you, sir. Good night.
Thank you. It was an excellent. Thank you very much.
Okay.